goal of this presentation is understanding how to recognise bone and cartilage, their specific characteristics when scanning with ultrasound. As discussed in a previous presentation, musculoskeletal ultrasound is not the golden standard to assess bone. The golden standard is still a simple X-ray. The problem with ultrasound is that the hardness of the bone doesn't allow any penetration of the ultrasound beam. As soon as the beam hits the bone, it will be reflected back to the transducer. That reflection limits ultrasound assessment of the bones. The very positive side to this is that it allows us to make use of ultrasound. If bone would absorb the ultrasound beam like muscles and tendons do, we couldn't do ultrasound. There wouldn't be a reflection of the beam. There wouldn't be a returning signal, and thus there wouldn't be tissue visualization. In this image, you'll see a scan of the acromioclavicular joint. Only the outer cortex layer of the bone can be seen. Due to its hardness, there is a lot of reflection of the ultrasound beam, which results in a bright hyperechoic appearance. Underneath the hyperechoic lining of the bone, you see only black, the acoustic shadow. This shadow represents nothing, no anatomical tissue, because the ultrasound system can't see this part. Previously, the beam had been reflected as soon as it hit the outer lining of the bone. You can clearly see the lining of the clavicle and the acromion. In between, you can see a dark zone, indicated by the white asterisk symbol showing the AC joint. Next to the beam reflection, there are a few other advantages of looking at bones in musculoskeletal ultrasound. Bones, and especially specific bony characteristics, can serve as a landmark. This helps in understanding the exact location of where you would be scanning. The shape of bones don't only tell you where you are exactly, but can also tell you a bit about functionality and biomechanics. In this image, you'll see the femoral trochlea of the knee. The patella glides in a proximal distal direction inside this trochlea. The morphology of the trochlea determines the biomechanics of the patella. For example, if the trochlea is deeper, there is more patellofemoral stability than if the trochlea is more shallow. In this example, the anatomical variation in people tells you a bit who could be at risk for patellofemoral instability or luxation. In the left image, you can see the ultrasound appearance of the normal diaphysis of the radius. Please note that the red arrows are indicating the hyperechoic lining of the bone. But underneath this hyperechoic lining, we can see tissue instead of the to-be-expected acoustic shadow. This is a pitfall. In this example, you're looking at tissue which is actually not there. This is an artifact. This artifact is called reverberation, which is produced by a strong reflection of sound due to the marked difference in acoustic impedance of the soft tissues and bone. Reverberation is the opposite of anisotropy. Anisotropy is not seeing anatomical tissues which are actually there due to not scanning perpendicularly. Reverberation is seeing anatomical tissues which are not actually there due to perfectly perpendicular scanning of, in many cases, flat bony surfaces. In the right image, you can see radiographic correlation demonstrating the bone surface as continuous straight hyperechoic line. If scanning children, please be aware of some differences in anatomy due to the growth and development. In the upper ultrasound image, you'll see an example of the developing bone. The base of the middle phalanx is separated from the head of the proximal phalanx by a large break in the cortical bone due to the joint space. This joint space is indicated by the yellow arrow. The red arrowhead is pointing to the growing plate, which is responsible for allowing the shaft of the bone to lengthen until full growth is obtained. The epiphysis fuses to the diaphysis by bone when the cartilaginous growing plate becomes ossified. In the lower X-ray image, you'll see a radiographic correlation. So be aware of growing plates if scanning children. You wouldn't be the first one to mistakenly diagnose the growing plate as a fracture of the bone. Hyaline cartilage, my personal favourite anatomical tissue, is very complex and interesting. For now, we'll limit the information to what's relevant for musculoskeletal ultrasound. Despite its strong characteristics, hyaline cartilage contains 70 to 80% of water. This makes hyaline cartilage a strong yet soft anatomical tissue. Many bones are covered with a layer of hyaline cartilage. If this is the case, you'll see a very hypoechoic zone on top of the bone. This hypoechoic zone is the combination of hyaline cartilage plus the lubricating synovial fluid, both very soft tissues and therefore leading to a less echogenic appearance. In this image, you'll see the normal ultrasound appearance of a normal synovial joint, in this case the elbow. The red arrowhead at number 3 is indicating the bone of the humerus, the humeral capitellum on the radial side and the humeral trochlea on the ulnar side. The red arrowhead at number 2 is indicating the normal hyaline cartilage plus synovia as uniform hypoechoic band covering the hyperechoic subchondral bone of the humerus. Measuring hyaline cartilage could be useful to quantify the amount of hyaline cartilage present or to see if there are signs of osteoarthritis. Measuring hyaline cartilage thickness is fast, non-invasive and thus pain-free and showing a very good reproducibility. In this image, the MCP joint of a healthy subject was scanned longitudinally. The articular cartilage of the metacarpal head appears as homogeneous anechoic layer with clearly defined hyperechoic contours. These clearly defined contours offer good landmarks to measure the hyaline cartilage. Hyaline cartilage is not the only cartilage type that you frequently see in musculoskeletal ultrasound. Fibre cartilage can also be scanned. Hyaline, the left image, and fibre cartilage, the right image, are different structures. The main difference is that fibre cartilage contains more fibres, less water, and is therefore a harder structure. Knowing that fibre cartilage is harder than hyaline cartilage, which echogenicity does fibre cartilage have? Hypo or hyper-echogenicity? The answer to this question is that fibre cartilage is more hyperechoic than hyaline cartilage. In these two images, you see two examples of fibre cartilage. On the left side, the shoulder labrum, and on the right side, a medial meniscus of the knee.